Thank you. Thank you. So by definition, dyslipidemia is any sort of abnormal lipid level. So that could be high or low LDL, that could be high or low HDL. So dyslipidemia is a very, very broad term. Where we talk about hyperlipidemia is where we have elevated lipid levels. So you can have dyslipidemia if your HDL is too low, or you can have hyperlipidemia if your lipids are too high. We break this down best based on what kind of elevation we have. So if you have hypercholesterolemia, cholesterol, then we have elevated cholesterol. You could have lipoproteinemia. And then you can have hypertriglyceridemia. So what kind of elevation you have is going to dictate what kind of treatment that we are going for. In general, what we see is that cholesteremia is where your total cholesterol is above 200. Lipoproteinemia is where your bad cholesterols, like LDL or VLDL, are elevated. And triglyceridemia is where your triglycerides are above 150. So depending on what kind of hyperlipidemia you have going on, we have multiple different approaches that we have to worry about. When we look at the panel, when we look at a lipid panel, there are multiple different things that can get measured. But in general, what we're going to see is we have total cholesterol, which the goal is at a fasting level, you should be less than 200. Your HDL, the good cholesterol, when it's at goal, is above 40. Your LDL, your goal is less than 100. And your trigs are less than 150. This is fasting. Yes. This being said, cholesterol lipid panels are not as non-fasting is appropriate in most situations. It takes a while for these numbers to change. If you have we see this all the time, that if you have a really fatty lunch, like 4th of July, you're eating tons of burgers and hot dogs and all that stuff, we'll still see that in your lipid panel a couple days down the road. So what's important here is that we're trending it. Really, the biggest thing that is where we that's affected by fasting or not is triglycerides. So triglycerides are most affected by how soon did they eat a fatty meal, for example. When we boop, 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 boop. Da, da, da. Did he go into types? Did he go into like class 1 is familial hyperchylomicronemia? and all that stuff? Or did he just go into like ASCVD? ASCVD. Okay. When we are looking at someone's triglyceride levels, where we worry about them is their ability to clot. What we are essentially looking for is we are trying to figure out what the risk of a clot is over a 10-year period. So this is based on a pooled levels from a large community setting, and essentially what it breaks down to is duh, 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 duh. Is he's going to have you calculate the ASCVD, right? Not calculate, just use. Okay. Hmm. Okay. All right. I just want to bring up my notes, but it's not. Isn't this working? That's whatever. Um, Sorry, I'm just trying to get this to pop up. There we there we go. Perfect. All right. Do, do, do. All right. There we go. When we talk about ASCVD, what we're looking for is their 10-year risk for a cardiovascular disease outcome. So something like a myocardial infarction, or they have a stroke. So what we look for in ASCVD is first we need to establish, does someone have a clinical ASCVD? What really this comes down to is the idea of risk factors. Risk factors can be non-modifiable, which is things like your age. The older you get, the increased risk you have. Being male increases your risk of ASCVD, and certain races and ethnicities also have a higher risk. We can have modifiable risks if we have if someone is smoking. So if you quit smoking, your risk goes down fairly significantly. Untreated diabetes, as well as untreated hypertension. And then finally, and this is the big one, dyslipidemia. So this is where all the lipid drugs come in terms of the ASCVD. And when you look at the calculation of ASCVD, this is where why we worry so much about lipid levels and different aspects like that. Generally, what we say is we have 4 categories. You are low risk if you are less than 5%. You have a borderline risk if you're between 5 and 7.4%. You are at moderate risk if you are at 7.5 to 19.9, and then high risk is above 20. What these numbers mean is that you have a 20% chance of having a cardiovascular outcome in a 10-year period. So if they ask you about the outcomes of ASCVD, it's not that you have a 20% chance of having a stroke. It's that you have a 20% chance of having a stroke over 10 years, right? Which is a really, really, really big range, right? 10 years is a huge amount of time. That being said, a stroke can be devastating to anyone. So let's jump into the drugs and compare them. What we are going to do is we are going to look at the class of the drug. We're going to look at the effect profile, which means that we really care about the effect on LDL, HDL, and triglycerides. We should look at the adverse effects. And then some contraindications. The indications here are going to be pretty much the same, right? We have high cholesterol. So what is our first line drugs for lowering bad cholesterol? What is our first line drugs? Statins, exactly. Statins are incredibly good at preventing high cholesterol. They reduce cholesterol by a significant amount. And generally what we can say is that if you need high dose, you have clinically relevant ASCVD. What I mean by that is you have a prior CVD event. So that's an MI, a stroke, you had a clot somewhere. So any kind of clotting event is going to mean high dose. Likewise, I believe he wants you to know that if you are high risk, so your AVC, so if you don't have a prior event, but your ASCVD score is above 20%, you are automatically high dose statins. Where we can see some flexibility is in the medium intensity dose, the moderate. And for this, it really just boils down to that you are greater than 75 years old. And no clinical ASCVD. So for example, a 75-year-old could be on low dose or medium dose. Sorry, let me put it this way. If you're 70 years old, you could be potentially in low dose. If you are 75, as long as you don't have a prior stroke or you didn't have a heart attack, you can be on medium dose. The other factor that plays in for why you might be on a moderate dose is you can't tolerate high dose. So in other words, we tried to put you on 80 milligrams of atorvastatin and your muscles degraded. So obviously we can't bump you back up. You can't handle it for whatever reason. In terms of our statins have a major ability in decreasing LDL. That is their primary purpose. The reason, how we describe this is they have what's called a pleiotropic effect. Essentially, what this means is that they make plaques more stable. Remember that the reason why plaques can be so dangerous is that they start to form a clot around them and then they dislodge and wind up in a smaller vein somewhere else. So by using a statin, we make the plaque more stable and less likely to dislodge. In terms of HDL, statins raise HDL slightly. They're not that bad. And triglycerides go down. So in a lot of ways, not necessarily we're going to remove it, but more that the body can take time to degrade it over time. So only really if there's a issue with like a stent, like we need to put in a stent, are we going to remove a plaque or go around it? Yes. Oh, I see. Yes. The body will remove it. Yeah. In terms of adverse effects, the biggest one is myopathy. What we're talking about here is muscle pain. Where are they going to have muscle pain? Where in the body? Big muscle groups. Back, arms, legs, calves. All right. We're not talking about your abs. We're not talking about, around the ribs. We're not talking about your fingers. We're talking about large muscle groups. If someone has myopathy, what should happen to them? Should we just say lower the dose? They can't take it anymore. Right. So if someone develops myopathy, we need to stop the drug, make sure that they're not going to end up in rhabdomyolysis, and probably lower the dose. Unlike an ACE inhibitor, where, if you develop the cough, then we're never going to give you an ACE inhibitor again. If you develop rhabdomyolysis on a statin, can we give you a statin again later on? Yes, we can. And in fact, we can re-challenge the same dose, because what can end up happening is that maybe someone went for, their annual Thanksgiving Day walk where they walk a mile with, for a pie or whatever. Anytime that someone increases muscle breakdown, like through exercise, that puts them at risk of developing rhabdo. So maybe they develop rhabdo because they were increasing exercise, but it doesn't necessarily contraindicate the use. More likely than not, we're going to be reducing the dose. The other big part here is LFTs go up. What we're talking about here is things like AST and ALT. If you have a patient on if you have a patient on a statin and you notice that they have really, really high AST, ALT, that may just be because of the drug, right? We should see an increase on both. It should be a pretty balanced issue. In terms of contraindications, really the biggest thing is muscle disorders, right? They already have some sort of issue with their muscle. We're not going to worry about it. The other thing is if they're pregnant. Right? In terms of drug interactions, what are statins? What are they major what? What kind of inhibitors? 3A4. Very nice. P-glycoprotein, definitely. Uh, 2C9, some of them. What I would say is that they all affect 3A4 and certain ones affect P-glycoprotein. Some of them affect 2C9, but all of them affect the 3A4. Anything else from here? So if they have rhabdomyolysis, you take them off of the drug, right? That's part of the AKI treatment, is that whatever's causing the rhabdo, stop giving it. But later on, 2 weeks later, we might give them the same atorvastatin, but maybe at a lower dose. So when we talk about someone being intolerant, here we go. When we talk about someone being intolerant to the high dose, getting rhabdo would be a reason for that, right? The other point too is maybe if they're on like a 3A4 substrate and we don't want to give too high of a dose, right? So maybe we'll only give moderate intensity. Couple of other things to note about statins. When should they get administered? When's the best time to take a statin? They inhibit 3A4. We are going to take statins at bedtime. Why do we take statins at like crazy? Oh, you guys are so... I completely flubbed it. I was reading it wrong. They are substrates. They are substrates. They are affected by inhibitors. My bad. My bad. You guys are right. Anyways, the majority of cholesterol is made at when you're sleeping. So the reason why the reason why we take statins at bedtime is because the peak dose, the peak concentration happens when the majority of cholesterol synthesis happens. So one of the easiest interventions that you can make is moving their statin from morning to bedtime. Really, really easy way of intervening. Any questions about that? All right. Let's go to our next drug class. God, I can't draw in straight lines. All right. So we have class, we have LDL, HDL, and trigs. Then we have, I didn't give myself enough room, so I'm going to erase this. We have adverse reactions, contraindications. All right. The next one that we're going to talk about that have very, very similar properties to statins is the PCSK9s. The PCSK9s inhibitors are an add-on therapy for people who have a statin. So they have a statin, but are still have increased LDLs. Okay. So when you are looking to add a PCSK9, it's because one, their LDL is still really, really elevated, right? So they're on the highest dose of the statin available, atorvastatin 80. So we should put that in, right? High dose of the statin. But their LDL is still elevated. The other thing that you might want to just add on a PCSK9 is if they're a very high risk for ASCVD. So in other words, that we run their ASCVD and we find they're 25%, right? That's an extremely high risk. So where a PCSK9 inhibitor will come in is where we want to really, really lower the LDL. Just like the statins, these have a huge effect. So we're lowering LDL by about 50 to 70%. It's a huge amount, right? They have an ability to raise HDL and lower triglycerides. But again, their major factor here is that they are lowering LDL. In terms of adverse effects, they have very, very similar adverse reactions. The first is that same myalgia, right? The muscle pain, the myopathy, they have the same sort of problem. So if someone ends up with muscle pain, we know we have to take them off of the PCSK9. The other issue is that we have delirium with these drugs. All right. I'm not talking about, you forget a couple of things. We're talking about you don't even know what world you live in, right? You're saying that you're the reincarnation of JFK. You get super, super, super delirious with these drugs. In terms of contraindications, any history of allergy or what we say hypersensitivity is completely contraindicated. The reason for that is that these drugs, like alirocumab, these drugs are monoclonal antibodies, which means that they are essentially synthetic antibodies put into your blood. They're administered by a sub-Q injection, which I think this is twice monthly, if I remember correctly, 2 times a month, or every 2 weeks, I should say, Q 14 days. The big thing here is that these drugs, some people are just really sensitive to them. So they can have a really, really bad allergic reaction. So you have to be careful about it. Specifically, alirocumab interacts with statins. So if someone is on a statin, the half-life of alirocumab goes down. So they might need, a dose weekly instead of 2 weeks. It's a really good question. So the reason why statins cause myalgia has to do with where actually there's a really good picture if I remember looking at this. Essentially what ends up happening is that throughout the day, your muscles are constantly being broken down and rebuilt over and over and over again. What ends up happening is that by using the statin, they inhibit the ability for the mitochondria to be regenerated. And essentially what ends up happening is that they create a lot of lactic acid, which interferes with the electron transport chain. So a lot of what's happening in the muscle is that you're not allowing for the muscle to regenerate as it should. And then it just keeps breaking down without recovering at all, which is not good. Good question, though. All right. So we talked about statins, which are our main drug. And then we talked about PCSK9, which is sort of your alternative to, it's like your statins on steroids, right? They're very, very, very effective statins, essentially. What we're going to go into now is other drugs that can be useful or might be monotherapy. So, for example, the fibrates which includes gemfibrozil, fenofibrate, its acid form, fenofibric acid, benzofibrate, all those different ones. What these are is a second line adjunct to statins. So in other words, someone is on a high dose statin and we need to lower their lipid levels further than what we have going on. The biggest thing to know about the fibrates is that they have some effect on LDL. They have some effect raising HDL, but really where you should think of fibrates is in trigs. They have a huge ability to lower triglycerides. What about admin for PCSK9? Oh, administration is done by a nurse. It's done at a clinic because it's a sub-Q infusion. Only the statins have a specific administration that we worry about. Yeah, good question though. In terms of the fibrates, again, where are we going to be really using them is hypertriglyceridemia, right? So if you see someone has a triglycerides that are super, super, super high, we're going to be using it there, right? They're such a good, they are so good at over 500. If 500 is kind of high. At 500, you're at risk of pancreatitis. What I would say is like above 300. So if you're on a statin and you can't get below 300, that's when we would add a fibrate. If your trigs are over 500, then 175 to 499. Yeah, I mean, if your trigs are staying elevated with a statin, that's when you need a fibrate. They're an adjunct to statin therapy. If they're over 500, just when you check them, no matter if you're on a statin or not, you're putting them on a fibrate. Over 500 for trigs, you are at risk of pancreatitis, and it's automatically indicated. What's important to note here is that fibrates, even when they're used with statins, don't necessarily improve ASCVD. What they do is they protect the pancreas, which is really what we are using them for. We're using them for triglycerides, but because otherwise we're going to have a lot of issues backing up the pancreas and causing a lot of issues. Adverse reactions here are sort of mild. The biggest one that people have is dyspepsia. So they kind of have an upset stomach. It's not exactly like they have acid in their stomach. It's more like, their stomach just feels upset, like it feels nauseous in a way. The other big one is cholelithiasis. Does anybody remember what cholelithiasis is? Bile stones, right? So gallstones. We should also expect a increase in LFTs. So if you get a question on the exam that's like, oh, do we have to worry about this increase in LFTs in a patient that just started fenofibrate? No, we expect them to go up because of the drug. And then finally, we have myopathies because triglycerides are so integral to muscle recovery. So it is we see the same like muscle pain that goes on. These drugs are contraindicated in liver failure and renal insufficiency, meaning that if your kidney function starts to go down, you're not going to be able to take these drugs. And if you don't have myopathy is just dysfunction of the muscle fibers. So meaning that like the muscles aren't working correctly. So they are weaker, I would say, is the way of saying this. Weaker. Whereas myalgia is specifically pain. So you have weak muscles, but they may not necessarily be painful in a way. It's a good question. As kidney function goes down, you're going to get rid of your fibrate. If you have liver failure, we're not giving you a fibrate at all. It's just not going to give it to you. There is a pretty significant drug interaction between the fibrates and the statins. Even though that these drugs can be used together, we have to be really, really careful because you have an increased incidence of myopathy, and eventually this can lead to the rhabdo. Specifically, the biggest one that causes this issue is gemfibrozil. Does this mean that you can't give fenofibrate with a statin? No. It just means that you're probably going to be using the lower doses of both. That's really what the issue is. Any questions about those drugs? We all love kidney failure. By the way, if someone gets rhabdo, what's the main treatment for rhabdo? Other than take the drug away. Take the thing that's causing it away. Flush. Flush, flush, flush. Get that shit out of there. All right, let's bang out our last ones here. Niacin. Niacin is interesting because what it does is it decreases lipolysis in adipose tissue. And it's essentially blocking a hormone sensitive lipase is the issue, right? Where you are going to be using where niacin comes in is where you have high LDL with statin and ezetimibe, which we will talk about in a second. I should have done that one first. So if someone is on a statin, then you give them ezetimibe and it's still not working, then niacin is a good place to go to. It's a B vitamin. Are we giving you the doses that you would take if in your multivitamin? No, we're giving you much, much higher doses. But it has benefit only in these high doses. Should you tell someone to go out and like purchase their own niacin? No, it should be monitored. Then as long as they're gummies, it's fine if you overdose on gummy vitamins. Niacin has a really, really good ability to lower the LDL, has a very good ability to raise HDL, and it has a pretty small effect on triglyceride. The biggest thing here is that it especially OTCs, you get flushing and what's it called? Itching, pruritus. Lots of flushing, lots of itching, especially in the face. Can be pretty uncomfortable. You also, because the body isn't able to use its fat stores in adipose tissue, you're going to have an increase in blood sugar. So that can be a bit of a stumbling point, right? It's not totally terrible, but it can definitely be effective. Remember that niacin is nicotinic acid. This is going to decrease urine pH, which is going to potentially cause gout. So it is not one of the big contraindications for using niacin is gout. The other is that in very, very high doses, niacin is not good on the liver. It can cause some pretty significant damage in terms of free radicals, I believe. So it is not great. In terms of drug interactions, niacin interacts with alcohol pretty significantly. So you get much, much worse adverse reactions. So you're like, if normally your cheeks turn a little red, all of a sudden your entire face will turn really, really red, be really, really itchy as well. The other is that you get pretty significant liver damage. And again, we're talking about really high doses of niacin. We're not talking about like your multivitamin. Any questions about niacin? What's your question? This is LDL, HDL, and trigs. So primarily its biggest thing is that it's working on HDL in the first slot. Oh, no. This is the indication. Sorry. So you're utilizing it when your LDLs are still raised and you're on a statin. And then yes, pruritus is itchy. All right. Let's jump into probably the favorite drug of the bunch, which is ezetimibe. Ezetimibe, first I just want to show what it does, is that it has a very good ability to lower HDL lower LDL while having a meager to no effect on HDL, right? So ezetimibe is pretty much focusing on the LDL component. So it's not really a good drug if you need to raise HDL or if your trigs are kind of out of whack as well. That being said, if you are on high dose statin and it's still not working, you go to ezetimibe. So in terms of what your algorithm is, first you get to high dose statin. If that does not work, you go to ezetimibe. It is a very, very good second line. The other thing, so this would be the first part. The second part is if you have contraindications to statins, you're going to use ezetimibe. So if you're pregnant or you're allergic or all those sorts of things, you're going to go to ezetimibe. Ezetimibe plus statin therapy is very, very, very good. Combination therapy of statin and ezetimibe is very key for a lot of people. So a lot of times what will happen is that if you have an old person who can't tolerate high dose statins, what we'll do is we'll keep them on atorvastatin 40 with ezetimibe because that will help accomplish the same goal. Why don't we just give ezetimibe to everyone? Is because some people don't necessarily need two drugs, right? We want to decrease polypharmacy as much as possible. In terms of adverse reactions here, we're going to get an increase in LFTs, but really the biggest one is pretty significant diarrhea, right? I am talking about you are shitting your pants. Like it is pretty bad. So what would be sort of a recommendation you should say to someone when they first start ezetimibe? What should they pick up from the pharmacy or from the drugstore? Yeah, right. Probably an antidiarrheal. Maybe to increase the fiber in their diet. That'll help, create bulk, and maybe it won't be so watery, right? Also avoid things like coffee, right? Things that will make them have worse stools. The only contraindication here is that in liver failure, So with someone who has active liver failure, no combination of statin and ezetimibe. Right? All these drugs are sort of toxic to the liver. So in someone who has liver failure, you do not give both of these drugs. All right. In other drugs like the fibrates, all that sort of stuff, in liver failure, if you had to, could you give it with a statin? Sure. But specifically the combo between ezetimibe and statins, no good in liver failure. Does old people being constantly constipated balance the diarrhea out? It could. The problem is that usually it's not like diarrhea in the sense where it's really watery. It's diarrhea where it's really oily. That's the problem. So you have like really, really fatty stools and they smell really bad. So if someone ends up not making it to the toilet, you can pretty much tell immediately. It's pretty bad. Should I keep talking about it? Do you guys want to learn more about old people stool? All right. Last two. In terms of bile acid sequestrants, at one point in time, these guys had their place in therapy, but they just have fallen out of favor because their side effect profile can be pretty bad. So what these drugs are doing is that they are inhibiting the intake of fatty acids and cholesterol and stuff like that at the brush border, right? So inside the intestine, they're preventing the uptake of bile acids and stuff like that. Really, where these are coming in is where we want to lower LDL and we don't really care about HDL or trigs. That's where they're coming in. Where you would choose a bile acid sequestrant is if you cannot use ezetimibe, right? No, I wouldn't say pregnant patients should be given ezetimibe. No, I wouldn't say. Yeah, I don't think that would be a good combo. All good. Bile acid sequestrants, they're not getting absorbed into the body, so their side effect profile isn't very systemic. But really what we are using them for is to lower that LDL. Because you are not absorbing as much fat from your diet, you're getting way more fat in your intestines. Oh, I see where your question came from. No. So in pregnancy you can't take a statin, and in pregnancy you can't take Zetia either. Both of them are contraindicated. What I mean by like contraindication to statins is like if you can't if you have an allergy to it, or if you you have a muscle disorder, for example, right? Or if you're taking a lot of like CYP3A4 inhibitors, it wouldn't be a good idea to take a statin, so we could put you on ezetimibe, if that clarifies. So all the feelings that you have about like when you eat a ton of fried food, I imagine that all the time. So you get nausea, bloating, cramping. It's pretty bad. Fatty stools. It's a pretty tough thing to manage. The problem with the bile acid sequestrants is that they cause an increase in triglyceride absorption. So the contraindication here is if your triglycerides are already elevated, right? Because if your trigs are already really, really high, and then all of a sudden we're adding a drug that's going to make them even worse, we don't want to use a bile acid sequestrant. The other thing too is if you have a bowel obstruction, don't use bile acid sequestrant. What I mean by that is like if you are if someone has an impacted bowel, right? It's not good to give them something that's going to cause essentially their intestines to push harder. Not good. Last thing that I would say here in terms of drug interactions is that these drugs prevent or not prevent, they decrease the absorption of fat soluble vitamins. Does anybody know the fat soluble vitamins? Birth control is not a fat soluble vitamin, but A, D, E, K, right? So vitamin A, D, E, and K, those are all going to be contraindicated, as well as lots and lots of drugs need to be separated. Birth control, warfarin, tons and tons and tons of stuff. Warfarin needs to be is a bad drug interaction because it's dependent on vitamin K. So you're going to be changing it. What would an adverse drug reaction for ezetimibe be? Diarrhea. So very, very similar. Any questions about this? All right. All right. I think we can pretty much leave this here. I think this just helps go through all the information. I don't really want to dive any deeper because it's just going to be a repeat of the lecture exactly. We have other stuff to talk about. Any questions about hyperlipidemia at all? All right. Make sure you know your cholesterol, your high versus moderate dosing of your statins. You would definitely be asked a question about what counts as a high dose statin. 100%. We need to start with VTE. VTE or CAD and PAD. No, we should do PAD. All right. Moving right along. All right. Oop. PAD, peripheral artery disease. Peripheral artery disease is, oh, yes. Oh, were we doing CAD or PAD? Angina's worse. We can do CAD instead. That's fine. All right. Let me bring up those notes. There we go. No. Where are my notes? Oh, I don't know where those notes went. Oh, maybe they're in. It says it should be in this one. VTE count. I don't know where.
It's under Getzig.
Oh, I'm trying to find my old notes from when I took the
Oh,
class.
never mind.
Apparently, we never went over coronary artery disease, but that's okay. You guys will just
That's
have to
lovely.
tell me what was and what wasn't in there. But we can still talk about it. All right, CAD. The biggest thing about CAD is that we have an ischemic condition in the heart, right? In other words, we have something called stable angina. What this essentially means is that we have a partial reduction in oxygen being delivered to the coronary tissue. So the blood supply to the myocardium itself is decreased. What we explain here is that we have an imbalance in oxygen supply and oxygen demand. And what ends up happening here is that the demand pretty much stays the same, but the supply is going down and down and down, which in turn increases the demand. So what ends up happening is that we get our two parameters going in opposite directions, and then you get lots and lots and lots of issues. In terms of where this is going, where we have big issues, is when we look at CAD in general, we have two main categories. We have chronic stable angina, CSA, and we have acute coronary syndrome. The basics of this is that in CSA, we have a stable plaque, meaning that the body has a buildup of plaque in the coronary artery, but for multiple different reasons, that plaque isn't dislodging. In ACS, which you guys will go into 5th year, we have a plaque rupture, which leads to myocardial infarction, right? And then we can talk about, is it ST segment elevation? Is it not an ST segment elevation? STEMI and STEMI, all that kind of stuff. But that's generally what we're worried about. So here we have a condition where someone has chest pain, but it's not necessarily a heart attack, right? So the heart tissue is still getting some oxygen. It's just not enough that would result in explicit occlusion is a way to say it. Does that make sense? Does anybody have questions about that? All right. I'm thinking we should probably focus on the treatment because that's what you guys are probably going to Yeah, but let's start that. All right. The basic overview of we'll do a lot of cases tomorrow as well. The basic overview for treatment. All patients who have chest pain, all patients who have CAD get pharmacotherapy. All right. There's no non-pharm only for CAD. We will do lifestyle changes, but you automatically get pharmacotherapy. The biggest aspect of this is that we want to start prevention of recurrent chest pain. So we're trying to decrease future episodes of CAD, and we're going to start anti-anginals. So in other words, we're trying to make the problem, we're trying to stop the problem from getting worse, and we are trying to prevent instances of chest pain. Some patients have to go through a surgery called revascularization. Is this something she talked about in class? Maybe briefly, right at the end. Essentially what this means is that you have to have a surgery in order to bypass that that blood vessel that's blocked. So this would be something like a PCI, percutaneous coronary intervention, or maybe something like a CABG, coronary artery bypass grafting. So some patients who have really, really bad angina, we're going to have to do a surgery. Does that make sense? Okay. All right. You guys ready to completely demystify everything that you need to know? You're going to love this. All right. Anti-anginals. First of all, when are you going to be, why are we giving these? It's because of chest pain, right? So why these drugs pop up is because the person is having chest pain and we want to stop that chest pain. The goal of anti-anginals is to decrease oxygen demand. It has nothing, the anti-anginals don't necessarily have a direct role on increasing supply. The main thing here is to decrease demand. First line, what are you going to start with? What drug class? Nope, before we even get there. Beta blockers. Right? Someone's going to get on a beta blocker. Second line, nitrates, calcium channel blockers, ranolazine. When we think of medication therapy, a lot of times we automatically go to the nitrates, right? Because that is where we think of their utility, right? Where are we only using nitrates? Angina. So it must be that they're first line. They are not. Where these drugs come in place, why you are choosing a nitrate or a calcium channel blocker or ranolazine is firstly, it's an initial monotherapy. Initial monotherapy when beta blockers are contraindicated. What's a potential contraindication to a beta blocker? Heart failure. Well, we can give a cardioselective beta blocker, right? To prevent the asthma issue, right? Bradyarrhythmia. Conditions where maybe we don't want to decrease the action on the heart too much, right? So in other words, we're replacing a beta blocker because we can't use it, or it's a combination with a beta blocker because beta blocker isn't sufficient alone. All right. So it's either nitrate monotherapy because we can't give a beta blocker, or we give a combo because the beta blocker alone isn't working. Uh, the yes. What's your confusion? The reference. The BB is Ken. I don't know what that means, but as long as you feel good in your heart, that's all that really matters. All right. If you are still not getting if you're not preventing angina with a beta blocker, you add a nitrate. This is where you add ranolazine. Yes, is it second line, meaning you could do a beta blocker and ranolazine? Totally. But where this comes in is that you've tried everything else, you have to go to ranolazine. All right. So this is useful in terms of we need a third drug, do ranolazine, right? So you can do a beta blocker, nitrate, and ranolazine. It will get the job done. Couple of things to note here. That's not really important. Couple of do I want to? No, let's go into the other category first. Let's go into the other drugs, and then we'll talk about stuff. All right. Let's talk about CAD. So here we're talking about preventing it from getting worse over time, right? So in this case, we're trying to choose drugs that are going to prevent situations where the demand on the heart is either too high or the supply isn't good enough. And so we have different drugs to choose based on what kind of goal we're getting to. So in terms of our next category of drugs, our cocktail, the first thing, our first goal, our goal that we're going for, right? If your goal is to prevent recurrence, and or progression, right? So someone has their first chest pain episode, they get really, really, really scared. And so we are worried about the possibility of it, turning into, instead of just a anginal attack, we're trying to prevent it from turning into a what are we trying to say here? Trying to prevent it turning into a heart attack. This is where we are, right? Preventing heart attacks. Or stroke, those sorts of things, right? We're trying to prevent a worsening issue. We have two things that we can do. The first is antiplatelets. So this would be things like baby aspirin, 81 milligrams aspirin. This could be things like clopidogrel. Or dual antiplatelet therapy, DAPT. Did she go over DAPT? Maybe. She went over two other drugs. Is it Rivaro, Roxaban, and it was other antiplatelets? Okay. All right. Dual antiplatelet therapy is basically where you're giving aspirin plus clopidogrel, right? So it's either you're giving just aspirin, you're giving just clopidogrel, or you are giving the combination of both. This is recommended for all patients. All CAD patients will get this recommendation. Everyone who has CAD, so you have some sort of anginal attack, you're getting on an antiplatelet. The reason we want to prevent MI. The other option here is that we want to start an antihypertensive. What is our go-to antihypertensive? What category? Nope. Before we get into, well, yes, calcium channel blockers, but before calcium channel blockers, ACE inhibitors. ACE inhibitors, and obviously if you can't do an ACE inhibitor, an ARB. And then what is the other option? What is always a good option for patients? So it goes ACE, ARB if you need it, diuretics. Right. By the way, this is always the stepwise approach, right? For if you're trying to lower blood pressure, first is an ARB, first is an ACE, ARB if you need to, diuretics are always second. 1 and 2, the wombo combo. Where we are going to be using these is for patients with diabetes, hypertension, heart failure, and chronic kidney disease. The reason why these drugs end up in part of the cocktail is because pretty much everyone who has CAD ends up with hypertension, right? So if you have hypertension and you have CAD, you're getting put on an ACE or an ARB, right? There's no ifs, ands, or buts. The next goal possibility is if you are preventing progression and decreasing anginal attacks, right? So essentially what this is trying to say here is that let's say you put them on an ACE and aspirin and they're still getting tons and tons and tons of anginal attacks. This is where we're coming in for our beta blockers. I almost don't want to explain it like this because I think this is just going to be confusing. Yeah, I'm not going to explain it like that. That's just going to be confusing. This was a silly idea that I had. All right. So we have our anti-anginals, beta blockers, nitrates, calcium channel blockers, right? And we have our drugs that prevent recurrence or progression. What this means is, in terms of the cocktail, right? What this means is the cocktail is made up of two things: anti-anginals and anti-progression. What I will tell you is you're going to choose two. All right. So what two are you going to take in terms of your anti-anginal? Beta blockers and usually sublingual nitroglycerin, right? A nitrate. What are you going to take in terms of your anti-progression? You're going to take one antiplatelet, which is normally the baby aspirin, and you're going to take your ACE inhibitor, ARB, if you need it. The only thing that gets in, we can actually, this is something that can get added in as well, is anti-hyperlipidemia, which is really where we're just talking about the statins, right? And the whole thing about this is that we're decreasing the plaque formation. And so you're going to grab one of your statins. And that's where your cocktail comes from, right? High dose statins, yep, because this is a clinically coronary artery disease, CAD, is a clinically significant ASCVD, right? It's essentially a mini heart attack. So a mini heart attack is a indication for high dose statins. Very good point. If you can tolerate it. And there's our cocktail, right? So what happens if you have heart failure and we can't do a beta blocker? What should we go to instead? What's a good alternative to a beta blocker? So we picked our nitrate calcium channel blocker, right? So what we do is we swap out drugs based on what can't be tolerated in the main cocktail. We got a really, really good question about what do we use the cocktail for? Basically, everyone. All patients end up on the cocktail. Where we swap things out is dependent on the patient themselves. So for example, if you have an aspirin allergy, you use clopidogrel. All right. So we have a patient, they're allergic to aspirin. swap out the aspirin for clopidogrel. Or we have a patient that, is allergic to ACE, put in an ARB. They can't handle an ACE or an ARB, put in a diuretic, right? If they can't tolerate high dose statin, we just went through a whole hour of, different statin alternatives, right? Does that make sense? Does that make this process much easier? Okay, that's really the biggest thing. So when in doubt, give them the cocktail. Why you would change the cocktail is because they have a contraindication to one of these things, right? That's the biggest thing here. Alrighty then. Let's jump into VTE very quick. It's going to be so simple. You guys are going to be shocked. You're going to be like, oh my God, I can't believe it was this straightforward. Was this the last lecture before the exam? Yeah. All right. Da, da, da. All right. VTE. VTE is venous thromboembolism is a umbrella term that covers two other kinds of conditions. Essentially what it is that VTE is a large thrombus, so a clot that forms in the pelvis usually, dislodges and then travels to somewhere else in the body. What ends up happening is that depending on where that thrombus travels, we get different conditions. If the thrombus travels to the lung, we end up with a pulmonary embolism. If the thrombus gets lodged somewhere in the leg, for example, so instead of going up towards the lung, it goes down to the leg, you have DVT, right? A deep vein thromboembolism. In either way, both are essentially the same issue, right? We have a clot somewhere in the body that is causing an issue. When a VTE event happens, it's because a clot has already formed and has dislodged, right? Because of that, we can't just prevent future clotting. We have to break down the clot that is already there and then prevent future clotting, right? So we don't want, we are trying to break down what has already formed and then prevent future progression. All right. Da, da, da. All right. So like I said, first steps first is we need to start anticoagulation. Anticoagulation is all about breaking down current clots. Oftentimes, anticoagulation will be started even while we are waiting to, see if it actually is a pulmonary embolism or a DVT. Essentially, what it is that we're trying to start treatment as quickly as possible. I just lost my place. Okay. In terms of our initial therapy, right? Someone is in the hospital and we need to break down the clot that has dislodged. Where we are going to start is, first of all, with the DOACs, the direct oral anticoagulants. This is first line. The DOACs are beneficial because they are easy to administer, right? You can administer them by mouth. And the biggest thing is that they can go hospital to outpatient, meaning that you can keep someone on the same drug. They're low in cost, and they increase adherence. The problem with the DOACs is that they are in low risk VTEs only. If you have someone who is not low risk, meaning that they have liver disease or they have no liver or renal disease, no they're hemodynamically unstable, meaning that they can't breathe or they're unconscious, something like that. Yes, PESI equals 0. Exactly. This is where DOACs are being used first line. If you can't use a DOAC, meaning that the patient is too unstable, we are going into our heparins. Where you're going to go first, so in your unstable patient or high risk, first you're going to be doing your low molecular weight heparin, which is things like enoxaparin or fondaparinux. These drugs, so we'll say this is second line. These drugs are preferred in normal renal function. And they are preferred in pregnancy. If for whatever reason your renal function is too low, this is where we get into our third line agent, which is unfractionated heparin. It's not that unfractionated heparin is bad. It's just that we have better drugs, so why not use them? So this is preferred in renal failure. So what this means is that if you looked at the serum creatinine, it's above, 2.7, right? It's really, really, really high. Or there is a plan for surgery soon. So if you know that the patient is going to immediately undergo, a surgery to get the clot out, we'd start them on unfractionated heparin. If we're not sure if that's going to be the plan and their kidney function is good, we'll put them on a DOAC or low molecular weight heparin. Any questions about this? All right. As soon as possible, get them off of these IV agents and onto a DOAC. So if their renal function improves, or if they were originally unstable and they became stable, go from enoxaparin to rivaroxaban or to edoxaban. Get them onto the DOAC as soon as possible. Once you have your initial therapy, so they're in the hospital, then we have our long-term anticoagulation. Let me change my color. In terms of long-term anticoagulation, what we're talking about is up to 3 months. Can it be longer than 3 months? Sure, but we're going to have slightly different parameters. The biggest thing is that for long-term, first line is our DOACs. Apixaban, rivaroxaban, great drugs. The reason why we're going to prefer these is because they are easy to take and they have few drug interactions. If for some reason someone cannot tolerate a DOAC, that's where we throw in warfarin. When we talk about warfarin, we always have this therapeutic goal of INR 2 to 3. Everyone has the same goal, 2 to 3. If for whatever reason, someone cannot tolerate warfarin, or you have to be really careful with warfarin because you have to take it very consistently. Your diet has to be very, very consistent. Then we can go to our third line agent, which is enoxaparin. Remember that enoxaparin in this setting is an IM injection. So would enoxaparin work better than warfarin? Usually yes, but the reason why enoxaparin is third line is because people really, really, really hate injecting themselves. So one of the best ways that we can get them to be adherent is to give them the warfarin, that sort of stuff. If after 3 months, after 3 months, we reassess if they still need to be on the anticoagulation. If we don't think that they do, we can stop it, and then we follow up after a year. If, for whatever reason they have a pulmonary embolism, then it's a pretty good idea that, okay, you're going to be on this for a long, long, long time. Does this make sense? Does this kind of clarify what the steps are? Okay, that's the biggest thing. when you look at the drugs, they have lots and lots of different parameters to them. Really, the biggest thing that you should, when you're going over the drugs here, is you should be looking at. No, they cover pulmonary and DVT. They cover both. Yeah, quick, right? Quick. Um, pulmonary embolism, it uh it depends on like the size of the pulmonary embolism, but a lot of times they're just going to follow the same thing, right? If it's submassive or if it's non-massive, you give a DOAC. If it's submassive, yeah, it you can break it down like that, but the thing is it follows the same pattern, right? Non-massive pulmonary embolism, you give a DOAC. If it's submassive, you give warfarin and a low molecular weight heparin, right? And then if it's massive, then you get into like heparin, uh, enoxaparin, maybe alteplase, those sorts of things. Um, but you know, it follows the same pattern, right? As things get more and more severe, you use more and more severe drugs. It's just what it is. For all of these drugs in this section, what you should take a look at is if they can be taken with or without food and the renal cutoff. All right. Which drugs can be used with which renal function? That's the biggest thing. Usually the cutoff is if their creatinine clearance is usually above 30, but 15 to 30 depending on the drug itself. But that's really where we worry about. What he put, okay. There's one of them, I can't remember off the top of my head that it's 15. In terms of our low molecular weight heparin, so our enoxaparin, that sort of thing, we really, really care about weight-based dosing. Yes, dabigatran is lower at lower creatinine clearance. So 60 is the cutoff for dabigatran, half the dose below 60. Yep, this would be enoxaparin. For fondaparinux, the biggest thing here is renal function and weight. Am I crazy? Why am I thinking of the wrong thing? Oh, because I'm thinking of outpatient dosing. That's why. For fondaparinux, we care about less than 50, 50 to 100 kilograms, and then over 100. So this would be 5 milligrams sub-Q, then 7.5 milligrams, and then 10 milligrams. This is really the big aspects of these drugs. The last one that has a lot of parameters to it is warfarin. So it has tons of drug interactions. It's interacts with 3A4. It's highly protein bound. P-glycoprotein, tons and tons and tons of stuff. Yes, actual body weight. Yep. So you put them on the scale. How much do they weigh? You have to be consistent with your vitamin K, right? So it's not cutting out vitamin K from your diet. It's about sticking to the same amount. So if you have a spinach smoothie every morning, you have to have a spinach smoothie every morning for the rest of your life while you're on warfarin. Or at least, talk to the warfarin nurse before you change. Trying to think if there's really anything else I'm missing, but really this is what we worry about. Yeah, I think this pretty much breaks this down. Yeah, I really can't think of anything else that would be really needs to be included here. This is essentially what it breaks down to. So as things get worse, you move your way up. Any questions about VTE, which again, remember, covers DVT and PE at the same time? All right. Sweet. All right. So tomorrow we are going to meet at 7 o'clock. It'll be a longer session, 7 to 10. And I will see you guys tomorrow.